In this module, we'll discuss in detail via voice over PowerPoints and videos um, the newborn assessment, how nurses conduct newborn assessments. And so these assessments depend on setting and are individualized based on the needs of the family and the newborn. They should be comprehensive. We should do them consistently the same way. Um, because doing them that way helps us to remember the order and helps us triggers if there's abnormalities from one exam to the next. And so knowing that head to toe is the most common order, and preferably we would want the infant in that quiet alert stage, and then we want to do vital signs such as heart rate and respirations first when the baby is quiet, because once we start to palpate and move and start touching the baby, um, it's going to be a less quiet environment. So I've divided the nursing assessment into two parts. There's this immediate newborn nursing care that we must perform from the time of birth through that first 2 hours of life. And then there is the assessments that are done after that 2 hours of life all the way up until to discharge. And so keeping in mind that we as the RN are the primary care provider for that infant, for that newborn, and we should start thinking about anticipatory guidance. You know, what things should we anticipate based on the data that we know? And so the data that we know should come from the antepartum and intrapartum histories. You know, what was the mom's pregnancy like? Was she diagnosed with gestational diabetes? Was she preeclamptic? Did she, what's her group beta strep status? Was she treated for any sexually transmitted infections? Those types of deals. Is this her first baby, second baby, etc.? And then during the intrapartum period, how was the labor? Um, did the mother receive any IV pain medications? Did she have an epidural? What was the bag of waters like? Was there any meconium? Those things gives us some ideas of things to anticipate if there was any break from the normal process of pregnancy and labor and delivery. And so a detailed history is essential, that we get that information either via the charts from the nurse that we are taking over from, that we and the patient themselves and family members, to get a sense. Was it a C-section versus a vaginal delivery? Were forceps, vacuum, um, uh, devices used as well? So again, knowing those things helps us get a picture of things that we may anticipate when we're doing our newborn care. So one of the first things that is done regarding newborn care is done right at the perineum, and usually, and that's suctioning, and so it's usually done with a bulb syringe by the midwife or the obstetrician who's doing the delivery, and we're trying to clear any fluid or mucus that may be in the mouth from being in utero, because again, when a baby comes out, it's going to take its first breath, and so we don't want to fill the lungs up with any more fluid. We want to get the fluid out and allow air to take up those spaces. So bulb syringes at the perineum is most common, and more vigorous suction is done at the perineum if there is meconium in the noted in the amniotic fluid when the woman ruptured, whether it was spontaneous or artificial. And we do this suctioning at the perineum again before that first breath because we want to prevent MAS or meconium aspiration syndrome, which would lead to major problems for the respiratory system if the baby aspirates meconium. And then we also do suctioning if there's a lack of spontaneous breath as a way to stimulate the newborn into realizing that it needs to take a breath. So here I want you to spend some time on this slide and really understanding APGAR scores. And so I provided a link to a video that goes into some details. But APGAR scores are basically the baby's first grades, if you will, that the nurse will assign based on various characteristics. And the APGARs are not predictive of newborn outcome or newborn health. What APGAR scores tell us is how the newborn is transitioning to this extrauterine life. You know, how is the baby coping with and making that transition from being a fetus to a newborn with all those changes that happens, changes from the fetal circulation to now the newborn, changes in the role of the lungs that was non-existent in utero and now the main source of oxygenation as a newborn. And so APGAR scores tell us how well this newborn is making that transition, and based on the score it tells us if we need to do some interventions to help with that transition. So APGAR is actually a mnemonic for the appearance or the color of the newborn, the pulse or the heart rate, grimace, reflex irritability. A is for activity or muscle tone, and then R is for respiratory effort. And so here I've given you the scale of how you score each one of those characteristics. And so knowing that scores of 7 to 10 means that there's good transition and then there's no interventions need to be done. Any scores less than that requires either moderate intervention immediate if it's 0 to 3 where we need to do neonatal resuscitation, or if it's anywhere between 4 to 6 there's some assistance, maybe some more stimulation, suctioning, or maybe applying some oxygen is needed. APGAR scores are done at 1 minute of life and then again at 5 minutes. And then if those numbers are still not at least a 7, then we would, after interventions, redo another APGAR at 10. So normally a baby who is transitioning well from intrautero to external life, you get a 1 minute APGAR and a 5 minute APGAR. Those with some difficulties would then have a 10-minute APGAR. And so again, I would encourage you to look at this link to go into detail of how we assess these 5 characteristics. And so in this immediate newborn period, the nursing assessments happen often. And so we start with the first hour. As I just said, we do the APGAR, so we have 1 minute and 5 minute assessments. Then there's a 10-minute assessment if needed, 15, 30, 45, and 60. So it's like we're going after that 10-minute assessment, we go every 15 minutes. And then for the second hour, we've spaced it out to half an hour. And so again, this varies depending on, again, if there's any complications, then of course assessments and interventions happen even more rapidly. And what we want to make sure is that, especially if a newborn is transitioning well, that we don't allow our nursing assessments to impede or have a negative impact on the family attachment, right? And that once you become seasoned and more comfortable, that some of these assessments can be done even while the mom or other family members or caregivers are holding the newborn, that they don't need to be taken away out of the arms of somebody who is uh, having a contact with the newborn, just so we can do our assessment. And so we're moving away from taking babies to the nursery and lining them all up to do their assessments and then bringing them back to the room. We're encouraged because of evidence-based research that tells us that rooming in, meaning keeping the newborn in the room with the mother, it has greater benefits than that separation that we were accustomed to, especially when I was on the unit. So, nursing assessments of the newborn in that immediate period or throughout the newborn stay in the hospital is necessary, but we don't want it to interfere with child parent attachment and bonding. And then we also don't want it to interfere with breastfeeding. If a mom is choosing to breastfeed, that we don't take the baby away from the breast to do an assessment, because we can tell some things by the fact that the newborn is in fact breastfeeding. We know that reflexes are intact. We can look and see if there's any retractions or how the respiratory rate is going. We can see if the baby is using its plantar or grasp reflexes. So those are things that we can assess without taking the baby away from the mom. Is the mouth blue? Is there any cyanosis going on? Is there any abnormalities with the woman who is breastfeeding? So again, this comes with experience and repetition, the comfort level of doing newborn assessments. Maintaining safe environments is always a nursing action, and if you're thinking about NCLEX, questions for NCLEX, and so identification of the newborn, immediately at birth, we apply bands to both the newborn and the mother, and usually one support person, whether it's the father or the partner or whoever the mother designates, gets a band that IDs the mom to the newborn, and that we should check that at every interaction. Whenever we take the baby out of the room and bring it back in, we ask the mother to read off her band, her ID bands, to make sure we match, even though we know for sure that that's her baby. We want to get into the habit of practicing safety. And in addition to the bands, there are alarms that are attached usually to loosely, not tight to the fetal. To the newborn ankle, so again, to prevent babies from leaving the unit without um, being properly discharged with the right families. I talked a little bit about vitamin K in that newborn adaptation module. And again, just to reinforce that, vitamin K is needed to help with clotting factors, right? And vitamin K um, is normally produced by bacteria in the gut. So, and the newborn gut is sterile at birth. And so prophylactically, we administer vitamin K IM in the thigh to every newborn within an hour of life. And there are families that may decline vitamin K administration, and families should know the risk associated with that those babies are at increased risk for having clotting factor issues of bleeding. There is a oral vitamin K route, but it's been shown to be less efficacious than the IM injection. And so the benefits outweigh the risk of administering this vitamin K prophylactically. Even if a woman is saying that I'm putting the baby to breast immediately, that the IM injection helps produce that vitamin K and get those clotting factors going quicker than even feeding the baby immediately. So it can be a supplement to that. And so again, you want to be respectful of families' wishes, but also making sure that they're making informed decisions and that you truly bring home the risk of not getting the vitamin K injection. And then trying to understand what is the apprehension. Maybe there are some myths or things that they don't understand that you can clarify as well. And then always document. And so it's document. You document that you administered the vitamin K, what route, where, and that you also document. And depending on your setting, there may be forms that parents sign to say that they were given information and they declined the administration of this medication. And you'll see this in the next slide as well when I talk about eye prophylaxis. So eye prophylaxis is required by law that all newborns receive erythromycin ointment, and it helps protect against a conjunctivitis in the eye that's caused by a gonorrhea or chlamydia infection acquired from the mother. And so you can tell, or you can see potentially why families would refuse, especially if they are confident that they have never had a gonorrhea or chlamydia. Then why would I apply this or have this medication applied to my newborn's eyes? And so again, it's discussing the risk and benefits of administration. So for example, I did not have gonorrhea and chlamydia with either of my pregnancies or at any time, but still opted for the eye ointment to be applied. And so we can delay this installation because there was a time where we wanted to do everything, where we had our checklist and we wanted to, take the baby from the mom, dry it off, administer vitamin K, put the drops in the eye. And again, those things interfered with parental attachment, skin to skin, and just the excitement of the parents in having an opportunity to engage with their newborn. And so through research, we know that we can delay the installation of this eye ointment for at least 2 hours, and that helps to accommodate, bonding, attachment, and breastfeeding and interactions between the newborn and its family members. It is the responsibility of the labor and delivery nurse who is conducting this immediate newborn assessment to get an initial birth weight. And so here I've given you some terms of depending on the grams of the newborn, what they're considered abnormalities out of the norm. So low birth weight, very low birth weight, extremely low birth weight are usually babies who are preterm. If there was some intrauterine growth restriction, these babies may be low birth weight even at term. And then on the other end, macrosomia, which we talked about, is more than 4,000 grams. And then I have the pounds in parentheses. And then keeping in mind mechanisms of heat loss that we talked about related to thermal regulation. So when we're doing the initial weight, we want to make sure that we decrease heat loss by conduction, by making sure that the warmer is covered. We usually put a sheet of scale paper there to so the baby isn't touching the cold scale, and that we want to do this quickly so that there is no heat loss by convection through the air. And then we wrap the baby back up or place the baby back to the mom's skin to skin. So on the previous slide, I gave you examples of newborn weights that are outside of the norm. So the average newborn weighs around 3,400 grams, and about 95% of all newborns are somewhere between 2,500 and 4,000 grams. And so I've also included here conversions, because families think of weight in pounds, and um, on the medical side we use grams, and so you need to be able to know how to convert those. And this is important when we talk about newborn weight loss and what's appropriate and how to calculate that. So you should be familiar with and memorize these conversions that I've presented here. So some weight loss is expected within the first 3 to 5 days of the newborn's life. Because if we think about, the loss of fluid in the lungs, the newborn is now voiding or having bowel movements. So there is some weight loss that is to be expected. Up to 10% of the norm of the birth weight is an appropriate amount of initial newborn weight loss. Any loss greater than 10% of its birth weight is of concern. We want to, know how the infant is feeding, what's its input and output, and that the newborn weight normally stabilizes within 5 days, and that it returns back to its birth weight by 2 weeks of life. And so this is why it's important, one, that we do that initial weight at birth, and then when we do the weight every day up until discharge, we do it at the same time. And it's also important that when we do discharge teaching, that we have in place the newborn's follow-up visit with its pediatrician, because and that visit is usually within 3 to 5 days of life, to assess any abnormal weight loss. And so weight loss up to 10% of the birth weight is normal. So here I've just provided an example, because you need to know how to calculate weight loss percentage, because again, as nurses, if we're doing the weight, even if we're in a pediatric office and we do the weight, we're going to compare that weight at 3 days of life with its birth weight, and then we need to be able to calculate to know if there's been significant weight loss, or is it within normal limits. So here's an example of a baby who was born at 8 pounds. Then we need to know how to convert that into ounces, and then what percentage of weight loss is the max that the baby can lose, and it would be 12.8 ounces is the max amount that we would expect to be within normal limits of weight loss. So also during our newborn assessment, we're measuring the length of the baby, and we usually do that on the scale with that paper that I was talking about. We make a marking at the top of the baby's head, and then we stretch those flexed legs all the way out as extended as we can and make a marking at the foot. Take the baby back to the mom or to the warmer, wrap it back up, and then we measure our two markings, okay? Because baby's not gonna, you say stretch out, it's not going to do that. So this is the most accurate way that we can do measurements of length. We also measured the head and chest circumference, keeping in mind that the head is slightly larger than the chest circumference, and we measure it at the both at the greatest diameter of the head and of the chest. And so the chest, we're going to come across the nipples, and around the head, we are going to come across that biparietal surface, that diameter. So in addition to getting weights in grams and pounds, we look at birth weight in relation to its gestational age. And there's three categories: small for gestational age, or SGA, appropriate for gestational age, or large for gestational age. And so this would take into account if we have a term baby, that we would expect that baby to be around, like I said, 3,500 grams or so. If the baby was at the 10th percentile for that gestational age at 39 weeks gestation, then it would be considered small for gestational age. And then large for gestational age if it's greater than 90th percentile for that age. And so there's calculations and charts that you plot. You find the newborn's gestational age, and then you plot its weight, and then it lets you know what percentile that baby is in, and if it's appropriate for gestational age or not. Here I've just again giving you another chart just to talk about key factors in that transition. So what normal respirations, heart rate, temperature, and color should look like, knowing that colors, acrocyanosis is a normal part of transitions. And again, that's why babies usually don't get a 10 on their APGARs, because their extremities, there's 1 point taken off because the extremities may still be blue. Again, a refresher regarding gestational age. You should know the difference between preterm, late preterm, term, and post-term newborns. And just wanted to point out a couple of things. Late preterm is a fairly new term within the last, I want to say, maybe 10 years that this label has, or classification has been used. And these are babies that are born between 34 and 36 6/7 weeks gestation. So 34 weeks all the way up to 36 weeks and 6 days gestation would be considered late preterm. And this came about because these babies may be appropriate in weight, they may not have at the onset, they look normal, and they usually go to the regular newborn nursery. But what was happening is that these babies would go home, and that mothers and family members would know that the baby is starting to have some respiratory issues. And that's because, again, at 34 weeks, even though externally and weight-wise, it's a normal weight, the lungs weren't mature, and that there was irritability and problems with feedings. And so we take a closer look even at these late preterm babies. And then post-term is born after 42 weeks. And it's important to know these terms, because when you're doing an assessment for gestational age, there are certain characteristics that distinguish preterm from term babies, and we'll talk about that on the next slide. So there's various types of scales to assess gestational age. One in particular is a Ballard scale that you have in your text. But I just wanted to point out some differences between premature and full-term babies. And we talked about lanugo already, that the more term a baby is, the less lanugo, that fine hair it would have. The same with vernix. The more preterm a baby is, the less mature it is, the more vernix you'll see. When in relation to the skin, a preterm baby's skin is going to be more translucent, that we're going to be able to see the veins. And again, with the skin and the veins being that close to the surface of the skin, and it's already transparent, that poses a risk for thermal regulation, right? And so the skin of the newborn, of the preterm newborn, is more transparent. The ear cartilage for a preterm baby compared to a full term, if we pull down the pinna, the top of the ear, and bend it, there should be a recoil, an immediate recoil, if the newborn is term. For premature babies, that ear recoil is slow, or it may not recoil at all, and you would have to move the pinna, the top of the ear, back up. And so, again, this is part of an assessment. When you're checking the newborn, you can do these things along with the other assessments that you're doing. Um, the labia, majora is covering the labia minora in a more term female, as opposed to a preterm, that the labia minora is the dominant feature seen in a preterm. The scrotum is descended in a mature male newborn. Um, and then there are the creases in the soles of the foot are more prominent the more term a baby is. And so if a baby has a smooth creases, smooth soles of the feet, it's usually preterm, compared to the deep creases of a term newborn. And so again, you use these visual assessments to see if they coincide with the gestational age that the baby's supposed to be. And what does that entail for other parts of your assessment? So now we've moved from that immediate newborn assessment to the type of newborn assessments done 2 hours after birth through discharge. And oftentimes these assessments are done, certain aspects of the assessments are done every hour, looking for color, cyanosis, those types of deals that you just kind of keep an eye on. And then again, this is where we can do a complete head to toe detailed assessment with the parents present. It's a great opportunity to teach about the amazing capabilities of the newborn. You want to talk to the parents about any variations, like to the skin, Mongolian spots, stork bites, any of those things, and what that means as far as how long or when will they resolve, if there's any interventions that are needed, etc. Offering support, encouraging, help facilitating attachment. The mom or family members can participate in eliciting newborn reflexes. Um, and so you want to include the family as much as possible, and as much as they want to, in the assessment of the newborn during this time period. So again, this assessment starts head to toe, after getting the heart rate and respiratory rate. We want to start with the face and the head, that we are observing the neonatal face for symmetry. Is there any droopiness on one side or the other. Everything should be symmetrical. And if there is not, if one side is sagging, that there may be paralysis. We talked about temporary paralysis caused by the use of forceps, or if there was a shoulder dystocia that we want to observe for symmetry. Here, I've listed some things to look out for when looking at the newborn eyes. Again, a good teaching point to parents is that, baby's eyes may be very dark um, initially at birth, and that the color may change or probably will change 3 months to a year. So, every baby's eyes may look black or grayish, and know that their true color is will develop over time. You also want to be aware of any conjunctivitis, any discharge from the eye. It could be transient due to they had erythromycin in the eye, or it could be a sign of infection. So if it's any, greenish discharge, crustiness, could be a sign of an infection, and that the sclera of the eye should be white. And so any tinged yellowness would signal jaundice. When observing the newborn ears, we talked about the assessments of the pinna and the recoil of the ear for gestational appropriateness, but we also want to note where the placement of the pinna, and that it should be right at or above the crease in the outer eye, the canthus of the eye. And so you do an imaginary line across from the corner of that eye across to the top of the ear, and it should be either at or above that eye. If it's low setting or low setting ears, can be a sign of a genetic or congenital anomaly, usually associated with Down syndrome. Again, assessing the newborn mouth. And again, when you're doing these assessments or as components of the newborn assessment, you can do multiple of them at the same time. So, for example, if you're listening to or attempting to listen to the heart rate, and the baby begins to squirm or fuss, with your clean gloved hand, you can insert your finger, and not only are you eliciting the suck reflex, right? The swallow and the gag reflex, but you also could then now move your fingers around to feel the soft and hard palates, checking for any cleft palate, meaning any opening or disfiguration of that hard palate at the top, the roof of our mouths. You can check the cheeks, the tongue. Um, is there any what we call Epstein pearls, which look like and feel like teeth, and they are just calcium deposits that will be absorbed. And so again, you can do these things simultaneously with some other aspects of the newborn assessment, but again, it comes with time and practice. When we're assessing the body of the newborn, the trunk, we want to start at the clavicles, and we're checking for any feelings of any fractures. Is it smooth? Do we feel any, if we lift the arms, do we hear any rubbing of bones? Is there any cracking going on? And again, knowing the history of um, the intrapartum period, was there a shoulder dystocia? And if there was, then we especially want to pay close attention to the clavicles. How are the arms? Does one arm seem longer than the other one? Is one arm flexed and the other one remains extended? So those are abnormalities that we would find if there is a fractured clavicle, which I'll talk about in another module. Again, checking the breast, feeling the areola for breast nodules. Both males and females may have what we call witch's milk, where there's a little bit of white discharge, and that's due to some of the estrogen crossing the placenta and remained in the fetal circulation and now newborn circulation. And so there may be a little bit of discharge. All right. At the time of delivery, the umbilical cord is clamped and cut to separate the newborn from the placenta. And so that there's a cord clamp that's attached close to the umbilicus. And it's removed after 24 hours if the cord is dry, because eventually the cord is going to change from that gelatinous moist um, cord to now, because there is no longer blood supply there, it's going to get dry, shrivel up, and eventually fall off. And so we want to check the site of the cord for any drainage, excessive bleeding, and that we used to apply alcohol to the site to help with the drying process, but now we no longer do that. That's no longer evidence based. And so our goal is to keep the cord area clean, and that just squirting warm water over the area, pat drying it, and allowing it to or air dry is best. And so we want to keep the diapers folded down and not covering or rubbing against the cord or the umbilicus site to decrease irritation or infection. And then you want to inform parents that the cord itself will usually fall off in about a couple of weeks. So there's nothing that they should do to hurry that process along, but be taught about signs and symptoms of infection. So if there's any greenish discharge, if there's foul odor, if there is a large amount of bleeding and redness in the area, they should notify the provider right away. Moving down the newborn, we're now at the hips, and we're checking for symmetry of the folds in the buttocks. So if we turn the newborn over, we look and see if there is the same number of folds on both sides. If there isn't, if one leg seems longer than the other one, or there's less folds, then we want to start thinking about hip dislocation. And then we do a check. We turn the newborn back supine, and we conduct what we call Barlow's and Ortolani's maneuvers. And so I've provided a link that gives you a demonstration of that. And with the Ortolani's maneuver, we're looking for a clicking sound, that the hip is being displaced, that the head of the femur is outside of the pelvic socket. And the same with Barlow's maneuver is when we push the femur up, that we feel that the ball pops out of the socket. We also, when we're looking at the newborn back, we're looking to see if it's straight. Is there any dimpling at the sacral area that can be a sign of a possible central nervous system anomaly? Things like neural tube defects is what we're looking at. And again, we talked about that the checking the patency of the anus is done by if the presence of meconium is there, then we know that the anus is patent. There is no need for us to conduct a rectal exam on a newborn. Next, I've listed normal findings for external genitalia for the female and male. And again, this is self-explanatory, so I'm not going to read these to you, but know the differences or what to expect in a normal exam for both male and female. And lastly, I wanted to conclude this section of the module with providing you a video describing how to conduct a newborn assessment. And so again, this video puts to visualization all of the things that I've discussed in the previous slides, and gives you a better understanding and visual of how to conduct such an assessment. The first newborn bath is not done immediately, and the main reason is because of thermal regulation, and that we do not want to increase the risk of hypothermia for the newborn. And so if a bath is given, it's usually given closer to 2 to 4 hours after life, once we've established the temperature, that the newborn has maintained an adequate temperature for at least a couple of hours. And what we're finding in the literature is it necessary to even do this quote unquote first bath? And are we wiping away normal microbes that can help with, that the skin needs to protect itself? And so there is emerging evidence about the need of the first bath. And when we say first bath, it's not a immersion in water, it's a sponge bath. And because of this still umbilical cord that is attached, and we don't want that to get wet, that we don't submerge a newborn in water until that cord has fallen off. And so you know how we get the nice tubs at the baby showers and things like that, that newborns should not use those or be filled with water until at least 2 weeks, when that umbilical cord falls off. And so we do a sponge bath, and we're starting from the cleanest to the dirtiest. So basically, starting with the eyes, cleaning out any normal discharge that may be there, cleaning the head, and all the while maintaining preventing heat loss through those 4 types of methods. So once we're finished, cleaning the fetal head, we want to dry it off and immediately put a cap back on. Once we've cleaned the chest and the arms, we want to make sure that we have a t-shirt of some sort. We're cleaning the legs and the feet, and then we leave the genitals and the rectum last. And then we want to recheck the temp after the sponge bath. And if the baby's temp has decreased, again, there's a couple of ways that we can warm the baby back up. Skin to skin, again, placing the baby naked body directly onto the mom's body, or the dad's, or whoever the other support persons are, barring that they have no fevers or their temperature is normal as well. Or we can put the baby under the radiant warmer and apply a thermometer electrode to monitor the temp. So we want to recheck, and if there is any decrease in the temp, we want to maintain or get that heat source back up. Another couple of things that we want to look for during that newborn assessment later in life is hypoglycemia. And so that's blood sugar, low blood sugars, basically less than 30 milligrams per deciliter in the first 72 hours of life, or less than 45 milligrams per deciliter after 3 days. And so we see symptoms of hypoglycemia if the baby's not feeding properly, if it's jittery or having very lethargic. We'd want to do a heel stick to check glucose levels. And if those levels are low, the first intervention is to feed. And so if the mom is breastfeeding, putting the baby to breast. If she is using formula, we want to feed the baby to get its sugars levels up. And so in the high risk newborn, we'll talk about what babies are at risk. And just a teaser or a spoiler alert, we're looking at babies who are born to diabetic moms, and I'll go into why they're at higher risk for hypoglycemia. And then in the following slide, I talk about nursing interventions, which you can again read on your own, and so I won't talk over that PowerPoint. Hypocalcemia has symptoms similar to hypoglycemia. So to differentiate between the two, labs are drawn. So um, glucose levels and calcium levels are drawn to differentiate between the two, and the history of the mom prenatally and intrapartumly can also help us with differentiating between the two. So a controversial topic that nurses in the maternal child world will be faced with is circumcision. And so the definition of circumcision is the removal of the prepuce covering of the glands of the penis. And so the foreskin of the penis is removed. And if you can guess what percentage of males in the US are circumcised based on the latest data, would you say it's greater than 50%, 50%, or more than 50%? So slightly above 50%. So around 60% of US males are circumcised in the newborn period. And if you think about where are more males being circumcised, what part of the country are more males being circumcised? If you think about the Northeast versus the South, or Midwest or the West, where you think that those are more likely done? What region of the country are they done? The Midwest. And the area where they're done the least on the West Coast. And so there are various reasons that people historically opt for circumcisions. The main one is cosmetic, or that they want their sons to look like the fathers. There's been some studies done that it decreases penile cancer. It prevents phimosis, which is the unretractability of that foreskin, where the foreskin can't be retracted. That it decreases UTIs in males, and a lot of these studies were done in Africa. And so are they translatable or transferable over to the States is kind of where the controversy comes in. And so circumcisions are not recommended by the American Academy of Pediatrics. However, there's an asterisk there, because the Academy neither recommends or not recommend circumcisions, if that makes sense. That they say that there isn't enough evidence to be for or against circumcisions, that it is truly the choice of the family. So a lot of recommendations come from this academy regarding standards of care for newborns and for pediatric patients, for kids. But when it comes to circumcision, they've not taken a side. Okay. And so you'll have a lot of families who are unsure of what they want to do, and they may ask you, would you choose to have this procedure performed on your newborn? And you have to ask yourself, how would I answer that? What would I tell patients? And so, as a midwife, certainly I've been asked, and I let them know that yes, I've had my son circumcised. And if they ask for the rationale, again, it would be cosmetic. I really didn't have a medical reason why I chose. I didn't say, well, I know it decreases penile cancer, because that wasn't reality. But again, you follow that up with, that was our decision, and here's all the information that I have regarding circumcisions, and so that you and your family can make your own informed decision. And that's what our goal is at the end of the day, to provide families, regardless if it's immunizations, if it's circumcision, if it's breast or formula feeding, is providing all the information we can in order for them to make an informed decision, and then supporting them in that decision, especially in circumstances where, such as circumcision, where there is no clear-cut benefit to it, to the male. So in continuing with providing informed information, um, we want to certainly talk about the risk associated with circumcision, because it is a procedure, a cut, that there's an increased risk of infection. Um, the male may have difficulty voiding. Um, there could be adhesions, and it also has to do with the experience and comfort level of the provider. Um, I do not, or have not, performed a circumcision. Um, there are some midwives who do, but a lot of times it will be the pediatrician or the obstetrician who performs it. Um, and know that there's behavioral effects, that the infant is going to have pain. And so he's going to be restless, there's going to be discomfort, he may not want to eat. Um, and so the families have to be prepared for that. And then we talk about teaching them, if they have opted for a circumcision, providing care for the circumcised penis. And so when I'm talking about circumcisions, I'm not talking about circumcisions related to religion that are done later in the home. These are circumcisions done in the hospital prior to discharge. So here I've listed our role as nurses in male circumcision, things that we need to do prior to the procedure, and those things that we do after the procedure. And then the NPO for 2 to 4 hours is usually reserved for those males who are formula fed, because research has shown, evidence has shown that breastfeeding prior to a circumcision has some analgesic effects on the newborn, and so that it can be used in conjunction with other preparations like local blocks or use of creams to numb the area. Diapering the circumcised male is extremely important, and an important teaching for families, that when diapering, we want to coat the diaper with Vaseline. When the newborn comes back from having the procedure, he will have a Vaseline gauze around the site, and when we change the diaper, we gently remove that gauze, and then we apply a generous amount of Vaseline on the penis and in the diaper, because we do not want that circumcised, that raw penis to touch the diaper, because then it sticks, the cotton sticks, and now there's even more irritation and problems. And so when we're doing our assessments, we want to observe for any bleeding. And note, heavy bleeding is abnormal. We want to make sure there's a void, and that usually, like I said, is delayed. And so we want to, talk to the parents and have them understand that the baby's, again, is going to be irritated, and how we clean the site. And so again, we're just squeezing clear water over the penis and applying that Vaseline directly onto the penis and onto the diaper. As part of the newborn screening are some genetic screenings that are done, and they vary from state to state. Here I've listed the state of Wisconsin and Illinois because these tests are routine, done in all newborns. So screening for sickle cell, for hypothyroidism, for galactosemia, cystic fibrosis, and others. And what happens is if there is any abnormalities that come back from those screenings, that the families will be notified via mail of what types of follow-ups need to be done. For example, my children were born in Illinois, and when my youngest was born, we did get information back that she has the sickle cell trait because I have the trait. Again, my husband didn't, so she was not at risk for having sickle cell disease, but she has the trait. And so the letter was to inform us of that and suggesting that we come to get counseling to understand what that means. And so, of course, me, thinking I know everything as a nurse, right? I didn't follow up, but I would encourage my patients to do such. Prior to discharge, here in Wisconsin, all newborns are screened, have their hearing screened. And so that's just part of routine. So when we're talking about discharge, is discharge appropriate? We have to make sure that all of these things are done prior to discharge. And so, I keep saying that teaching is a crucial part of the postpartum period. And again, when conducting these newborn assessments or any interactions you have with the family during this postpartum newborn time, should be a time of teaching. And so specific teaching related to newborn is listed here. And again, not making any assumptions, especially if the mom is a para, that she's had kids before, that she and the family know what to do. All right. So things such as, how often should she be feeding, which varies depending on if she's breast or formula feeding. Car safety. Do you know how to put the baby in the car seat appropriately? The schedule of immunizations and what immunizations are given prior to discharge, and then what's the follow-up of that. Important of sleep safety. Where is the baby going to sleep? Encouraging that the newborn not sleep with siblings. Is there smokers in the house? Things that prevent SIDS. You want to make sure that you talk and keeping the baby on its back, those types of deals. Cord and circumcision care, all those things need to be talked about and discussed, and that you have an understanding that the family has a handle on these things. And so again, it's a lot, and so you don't want to wait until the day of discharge when everybody's anxious to go home to try to now cram all this information into one setting, when there are ample opportunities when you do these newborn assessments to talk about bathing, to talk about cord care, to talk about feeding, etc. And then that spaces this teaching out. And so again, you want to talk about warning signs as well, which I have on the next slide, again about immunizations, which again are on the preceding slide. Um, Labor and delivery, postpartum nursery, nurses who work in maternal child care are required to have be certified in neonatal resuscitation, and just like CPR for adults, that they need to maintain these certifications, where you learn about ventilations, chest compressions, and medications, which are different than in the adult. And so again, it's just an FYI. And so again, the newborn assessment encompasses a lot of components that can be done simultaneously. Like, you can do multiple of them at the same time. Knowing the health history of the mom, her prenatal history, her intrapartum history, can help us with anticipatory guidance, things that we should be looking out for. Knowing what the norm is as far as how newborns transition can help us when we're doing the assessments of what abnormal is. And so again, if you need to go back and look at that video, if you need to go through this PowerPoint again, like with all other PowerPoints and all other modules, just to get reinforcement, I would encourage you to do so. And always, you can contact me via email.